case discussion. So thank you everyone for joining us for Project Echo Geriatrics. Really glad to have all of you. I'm Kate Bennett. I'm a geriatrician at the University of Washington. And this is just a great opportunity for interprofessional discussion. So I'm glad you all joined us. We will run the session like we usually do. We'll start off with a short didactic on a focused topic, and I'll introduce our speaker in a moment. And then after that, we will have a case discussion, which is really the heart of Echo, where we all can learn from each other in an all teach, all learn sort of setup, where we can talk about how best to improve the primary care for older adults, and discuss challenges that we face in our clinical practices. So I will go ahead and introduce our speaker now. We have Dr. Jacqueline Raetz, who is joining us today. She is a geriatrician and a family medicine physician who also practices not only primary care, family medicine, but also in the post-acute care setting, as well as palliative medicine, doing inpatient palliative medicine consults. She has a lot of great expertise and also is a really sought after teacher and has been teaching residents and students and faculty and others for a very long time. I've learned a lot from her over the years. So I'm glad that you get a chance to learn from her on this project, where she is a co-investigator on this CDC funded project to really improve the evaluation and management of cognition in primary care. So I'll let you take it away, but thank you so much for taking the time out to talk to us today.
Yeah, thank you for the introduction. I have tons of slides and I tend to be a fast talker. So if I go over something too quickly, I hopefully have plenty of time for questions. I'm Jackie Raetz, and like I had said, I've been working on this project, Cognition in Primary Care, that was funded by the CDC and the Gerontologic Society of America in the wee months of the pandemic, early 2020. And along with Barack Gaster, who's also a primary care clinician educator here, we have designed a 3-part program to improve the diagnosis and management of cognition in primary care. We have nothing to disclose. And the Cognition in Primary Care program consists of 3 parts. The first part is a CME, which itself has 3 parts. And I'm going to share with you much of the slides from part 1, making a diagnosis of cognitive impairment. But as this is a very short talk, I'm going to go through those very, very quickly. We've also designed some EPIC tools for our electronic health record here at the University of Washington, to help guide primary care doctors through the process of evaluating and managing cognition, and also sort of an on-site clinic workflow that we've implemented now to 14 of the 16 clinics in the UW neighborhood clinic network. So the learning objectives are many. Appreciate that primary care is well suited to address brain health and cognition, know who may benefit from an evaluation, how to perform a cognitive evaluation, how to identify contributing and reversible causes of cognitive impairment, and just how to distinguish mild cognitive impairment from dementia. So why now? Why was this a project that people have so many interests in? Well, the baby boomer generation is aging, and we currently know that there's about 6.7 million Americans who have dementia. 35% of people over the age of 85 likely have some Alzheimer's, and that's going to rise very quickly over the next 10 and 20 years, because as you can see from this graph, currently the generation before the baby boomers is super tiny. And as that generation passes on and the baby boomers age, there's going to be a lot more people in the age group at highest risk for dementia. But why primary care? Well, primary care already does a lot of things to help people protect their brain throughout the lifespan. So often we'll say, how do you prevent dementia? How do you keep people's brains healthy? And one thing you can remember is that brain health is the same. Keep brain health and heart health. Things that keep the heart healthy, keep the brain healthy as well. And primary care is already doing a great job promoting a healthy lifestyle. So promoting healthy diets, making sure that they recommend physical activity to all of their patients. And then for brain health specifically, we want to make sure we treat mental illness and encourage socialization and people staying engaged with people around them, as well as good sleep. And we've also learned in the last few years that there's risk factors for dementia throughout the lifespan. And primary care also is often involved in detecting and treating some of these. So as family doctors, I take care of kids. And we know that lack of early childhood education incurs a 60% increased risk of developing dementia in later life. Likewise, in midlife, things like hearing loss, traumatic brain injuries, hypertension, heavy alcohol use, and obesity can increase risk of late life dementia. And throughout the lifespan, smoking, depression, social isolation, diabetes, physical inactivity, and air pollution. So there's actually some postulation that up to 40% of dementia cases could be due to 12 potentially modifiable risk factors. And many of these items are things that primary care providers are already addressing in the clinic. But it's hard to diagnose dementia. So why should we bother? Well, we know that it's a tricky diagnosis to make, particularly in the early stages. It also carries a lot of stigma with it. So it's tempting for patients and their families to not want to talk about it, or even for providers to kind of skip over it and focus on things like hypertension and diabetes. That's more in our comfort zone. But we can intervene meaningfully if we identify dementia earlier. And how is that? Well, we can provide more appropriate care. If someone has dementia, we may reconsider some preventative care measures that perhaps they won't have the lifespan to get benefit from. We're going to modify communication, making sure that we maybe write things down or communicate changes of insulin doses or medications for hypertension with another person who can help with the patient and their medications, and make sure we align decision-making with goals. We can increase support and understanding by involving and educating family, and we can connect people earlier to community resources. We can improve safety by addressing driving safety, financial safety, and home safety. We can limit medications that we know harm cognition. We can treat conditions that contribute to cognitive impairment. And we can recommend advanced care planning. And that's setting up things like a durable power of attorney for healthcare while a patient is still able to help make those decisions. We can also initiate the lifestyle changes that may slow progression, all of those healthy things we talked about in that earlier slide. Before I jump into making the diagnosis, so I'm going to clarify some terms because there's a lot of different words that often come up when we talk about dementia and cognition. So cognitive impairment means that somebody has difficulty with one or more cognitive domain. And we often think of learning and memory as cognition, but there's actually many different cognitive domains. There's language, executive functioning and planning, complex attention, perceptual motor function, and social cognition. So although sometimes memory and cognition are used interchangeably, memory is only one domain of cognition. And then how do we define dementia? Well, the DSM-5 now calls dementia a major neurocognitive disorder, which, I had not heard of because that definition was not around when I did my training. And now the definition requires a significant decline from previous level in at least one cognitive domain, and deficits must be severe enough to interfere with independence of activities of daily living. The DSM-4 required that memory be one of the cognitive domains, but that is no longer required. So for the older folks in the audience, it has changed. And we have a new diagnosis that wasn't around in years past called mild cognitive impairment, also known as minor neurocognitive disorder. And that involves a significant decline from previous level in at least one cognitive domain, but the deficits are not severe enough to interfere with independence. That's a major difference. And we're going to come back to those definitions at the end after we talk about the workup. What causes dementia and MCI? Well, dementia is really an umbrella term. It describes symptoms that are associated with a lot of different diseases. But by far and away, Alzheimer's disease is the most common cause of dementia. Other causes can include vascular dementia, Lewy body dementia, and frontotemporal dementia. And mild cognitive impairment can be caused by those same diseases like Alzheimer's or vascular disease. However, only only 70% or so of people with mild cognitive impairment progress to dementia. 30% of people stay stable. And they may be people who are just having mild cognitive impairment from other types of conditions as well, such as sleep apnea, depression, polypharmacy, B12 and thyroid disease, or other advanced serious illnesses. But isn't forgetfulness kind of normal with age? Well, there are some changes to the brain as it ages, and it's ages like other organs in our body. Cognitive aging and the changes is not a disease. It's separate from things like Alzheimer's. It's a natural lifelong process that occurs in every individual, but can look very different from person to person. Some cognitive functions like vocabulary improve with age, and subjective cognitive concerns that people come to talk to their primary care provider about might be just due from normal brain aging. And so as primary care providers, we need to know the difference between normal changes with age and those that could represent warning signs of dementia, like I said. And so what are some of those normal age-related changes that people might notice? Perhaps people need help occasionally using new technology, like their new smartphones. They may get confused about the day of the week, but figure it out later. Perhaps they have trouble finding the right word. They may misplace things from time to time and retrace steps to find them. And they may develop very specific ways of doing things and become irritable when their routine is disrupted. And you may, for example, need a grocery list in order not to forget a few needed items once you get to the store, more so than when you were younger. And what are warning signs of dementia? Now, I'm a big fan of the Alzheimer's Association 10 warning signs of dementia. So if you have a chance, I recommend looking it up because it very nicely, in more detail than this, goes through, what is a normal change and what's a very similar kind of a change, but more of a red flag for dementia. So as you can see on the left-hand side, you have your different cognitive domains. And on the right-hand side, examples of things that might represent something that represents dementia. So trouble following a recipe that you've done for years, or doing your monthly bills if it's something you've never had a trouble with, trouble driving to places that you've been to before, organizing a grocery list, or remembering the rules for a favorite game, losing track of dates, seasons, and the passage of time, or having trouble not understanding something if it's not happening immediately, forgetting where you are, how you got there, trouble following or joining a conversation or repeating oneself, using words oddly or incorrectly, putting things in the wrong place, unusual places, or accusing others of stealing, using poor judgment when dealing with money or other aspects of life, no longer paying attention to keeping yourself clean, for example, and withdrawing from social activities completely that you used to enjoy. So this is a common scenario we see in primary care. You have a healthy older adult, not on a lot of medications, and perhaps you're doing a wellness visit, and then they mention, I've been worried about my memory. And so you have to decide, is this person need an evaluation of their cognition? And we have to recognize that dementia is vastly underdiagnosed. We're missing up to 40% or so of cases of dementia in our country. So currently the United States Preventive Task Force does not recommend universal screening, although many geriatricians disagree with that approach. So at the very least, we need to advocate for targeted case finding. If a patient or family member mentions a concern, you don't want to just ignore it. If someone answers yes on their annual Medicare wellness questionnaire that they have worries about their memory, you don't want to ignore it. Or if any of the rest of the people in your interdisciplinary team, your front desk, your medical assistant, your nurse notices that someone is not remembering appointments or not remembering their medications, you want to address it. And we've created a tool based on those 10 warning signs of Alzheimer's that can help a clinician decide, should I have this person back to do a full evaluation? So these are very similar to some of those warning signs that I went over. Have you noticed you more often forget things that just happen, like repeating the same question or same story 30 minutes later? Have you noticed it's more difficult to finish complex tasks like cooking a recipe or organizing your documents? Have you noticed being unsure where you are in a place that you've been to many times, like becoming disoriented on your usual route or in a building you know well? This is a screenshot of the sort of decision aid that we created that's on our website, which you'll be able to link to at the end of the talk. And at the bottom, you can see what are some normal changes with age. And this is not meant to substitute for clinical judgment. Again, I think the best thing is for you to review all of those 10 warning signs of Alzheimer's and use your best judgment to decide if someone should have a full evaluation. So, so the evaluation itself, we highly recommend in primary care that you don't try to tack this on to another problem-based visit or a wellness exam because it takes a little bit of time. We want you to have a patient come back for a dedicated visit. We strongly encourage them to bring someone who knows them well, like a family member or close friend. Not all primary care clinics have the luxury of being able to schedule longer visits. Some clinicians are locked into as little as 15-minute visits. But if possible, a longer visit or sequential visits need to be arranged. And just as a reminder to billing providers that a level 5 clinic visit only requires 40 minutes of total, including preparing ahead of time and wrapping up after. And we've broken down the cognitive evaluation into 3 relatively straightforward steps for ease. The first is a checklist to make sure you don't miss the key reversible causes and other factors you can fix. We recommend a validated tool to get input from a family member and assess cognitive function with a MoCA. This is what our cognitive checklist looks like, and we've created an EPIC in our electronic health record. Our electronic health record EPIC, we have some tools that have this checklist in it. Depending on a patient's other diseases and their other risk factors, you may get a lot more labs, but at a very minimum, you want to get a B12 and thyroid. You want to look at their medications, including anything they're getting over the counter at the drugstore, because there's a lot of sedating and anticholinergic medications that can really impair cognition that people may be taking and you may not even know. So obvious ones like opioids or benzodiazepines like Valium and Xanax, those are obvious ones. But sleep aids like Zolpidem can be problematic. Medications like oxybutynin that we use for overactive bladder can really impair cognition. And diphenhydramine, which is Benadryl and is in the popular over-the-counter sleep aid Tylenol PM, which is often used by patients and they may not tell you if you don't ask. It's important to ask about symptoms of sleep apnea and potentially get someone sleep study if you're worried about that. Sleep apnea can cause a lot of adverse health conditions, and cognition can be impaired if people are sleeping poorly. You want to ask about depression and treat it if it's present. You want to ask about alcohol use and other substances as well, but particularly even people who are mild to moderate drinkers, perhaps throughout their life they were able to tolerate it, but now when they're older, they may not be metabolizing it as well. It may be impairing their cognition, whether it's directly from the alcohol itself or through impaired sleep or other symptoms that it causes. And then we recommend screening for and treating hearing loss. It's a big landmark study came out this year showing that while hearing loss is a risk factor for dementia, if you treat it, that risk goes away. And so you're going to combine in your assessment the MoCA test, like I mentioned, and the family input. And for the family input, we recommend the validated AD8. You can get it off the internet in many places, but also our website. And I have all 8 questions listed out here. And this is a tool that you ask somebody who knows the patient well. Are they having troubles with judgment, less interest in hobbies or activity, repeating themselves, having trouble learning how to use a tool, gadget, or appliance, forgetting the month or year, having trouble with their financial affairs, trouble with remembering appointments, or daily problems with thinking and memory. And 0 to 1 is considered normal, and 2 or more makes cognitive impairment very likely. I found when I use this, it often prompts a lot more conversation and some really concrete examples that often help me decide, I think there is a diagnosis of dementia. For example, when I asked one family member, she said, yeah, my mom didn't remember a trip to Atlanta that we took 3 months ago. And that's definitely not normal. You're not going to just forget a trip to Atlanta 3 months ago. The sensitivity and specificity you can see above. It has also been validated when given to patients themselves, but it's going to be less sensitive and specific. We used to think that patients with dementia would never have insight, but we now know that with mild cognitive impairment and mild dementia, patients often do have some insight that they're struggling. Later on, they lose that insight. And we recommend the MoCA over the mini mental status exam, which is what I learned when I was in my training, because it's a better validated tool to assess for early stage impairment in the primary care setting. These are the scores, 26 and above makes cognitive impairment less likely. 20 to 25 is sort of in the middle, or maybe there might be cognitive impairment. Less than 20 makes dementia very likely. And in the middle, you may want to consider additional testing such as neuropsychiatric psychiatric evaluation if that's even available in your area. So let's put it back together and think about the definitions again. A MoCA less than 20, gradual cognitive changes over time, difficult with daily activities of living. That's a diagnosis of dementia. A MoCA that's a little bit higher, gradual changes over time with intact function. That's a diagnosis of mild cognitive impairment. And so in follow-up, if evaluation looks okay, keep encouraging brain health and consider repeating it next year. If you find contributing factors, treat those and reevaluate. If the diagnosis looks like mild MCI or dementia, arrange for close follow-up and say, this is a lot to work through. Let's schedule another appointment soon and talk about what this means and make a plan, which is the subject of our other CME lectures. So in summary, we can do cognitive evaluations in primary care. PCPs already promote brain health throughout the lifespan. We can rule out contributing and causative conditions and treat those. We can obtain history from a family member or close friend with the 88. We can utilize the MoCA and check if independence is impaired. And we can operationalize our superpower of longitudinal care, which is so important in older patients in general. So I'm a primary care physician. What's your superpower? And that is the end of my talk. Sorry to go 6 minutes or so over.
No, that's perfect. It's something you can't cover in 15 minutes, and that was really high yield. So thank you so much. We have time for some questions if anyone has questions. It's great if you can unmute, but if you cannot unmute for some reason, please feel free to put questions in the chat. And please do fill out the survey. That feedback is really important.
Yeah, so there's a QR to the survey, and then on the right-hand side is a QR to our website if you're interested. And you guys let me know when you want me to stop sharing once you feel like everyone's had a chance to get that.
Okay. Any questions? I have a question if no one else does. I was wondering what you have found to be successful ways to utilize your interprofessional team in a primary care setting in any of this process. Like, what tips do you have for all of us?
Yeah. So what we've found is that from clinic to clinic, the interdisciplinary team often varies a lot. So one way to utilize your team is, medical assistants can be trained to do a MoCA. So can, psychologists or even social workers. And so that is one way of sometimes helping this process be a little more efficient. We also have different folks who will do medicine reconciliation. So in some clinics, that's, the medical assistant versus a nurse versus a pharmacist. And sometimes to really do a medicine reconciliation, you have to get on the phone with the pharmacy and find out what they're actually picking up. So that's another way I think you can utilize them. And then, a lot of times, it's hard for me not to think holistically about older adults. Other things that are identified, like the hearing loss or vision loss or trouble with ambulation, you're going to refer them to OT, PT, audiology to get treated for those things as well. When we give these lectures just so people know, for the UW Primary Care Network, PAs, nurse practitioners, and MDs are kind of all on level playing field as a primary care provider.
Thanks. There's a question in the chat. I'm not sure if you're able to see it, and if you need to unshare your slide.
Yeah, I can.
Is fine. But you're able to see the question?
Yeah. So do you feel like the MoCA is best for all levels of education, literacy, and language as compared to the GP Cog and MMSE? I think it's better than the MMSE. It has been translated into probably 24 languages. It also has the MoCA also has a version for low eyesight and low hearing. But there is a lot of question about, for example, I have patients at my Harborview clinic who are non-English speaking and were never literate in their own language. And so some clinics that have a lot of patients in that category will use something called the RUDUS, which I've looked at, but I've actually never used. But it's, for example, Health Point, which is a large community health clinic system in the Puget Sound area, they will use the RUDOS because they feel it is better for education and literacy. And I see
That's the one we use over in the Harborview Senior Care Clinic most
is the
frequently.
RUDOS.
Mhm.
Great.
Elizabeth has her hand up.
Hi, I had a question on if you have a patient who has dementia and isn't sleeping well, then they have worsened kind of sundowning symptoms. I know that there's obviously, we want to avoid some sedatives, as those could worsen cognitive function, but is there a benefit to using them short term to try to regulate their sleep cycle and then getting them off of that? Or what do you recommend normally?
Yeah. So there's sort of three separate problems I'm hearing in that question. One is just sundowning itself, which can happen, in the afternoon. It's a poorly understood, well-documented pattern of increased agitation type of behaviors late in the day in patients with more advanced or moderate dementia. And I don't think there is a lot of evidence for any medication for sundowning. In reality, very often we wind up using antipsychotics, which have increased mortality in this population. So it really needs to be done sort of with talking about the risk benefit in terms of doing a trial. Then there's like just general trouble sleeping. So people who have broken sleep cycles, and in dementia, you do get some sleep architecture starts to get very disorganized. And so, it's like, when are they waking up? Sometimes, at the nursing home, they're maybe putting people to bed too early and then they're waking up at 3 a.m. So you have to kind of take a really detailed history and figure out, is this a sleeping problem? Is it a getting to sleep problem? Is it going to bed too early and waking up too early problem? Is it a staffing problem? Because maybe that's their cycle now. But your question was about medications. And then, and then some people can have like sleep-wake reversal, which is very, very hard to overcome as well. So, like I said, with the sundowning, sometimes if we can't, people will use medications like antipsychotics. Leading up to that, sometimes we'll try things like melatonin to try to regulate sleep. That's going to be a lot less risky, but it's not going to help like 4 p.m. sundowning, for example. There was once a Cochrane review many years ago that suggested melatonin doesn't help for sleep in people with dementia, but it may reduce agitated behaviors. There's one other study I found since then that corroborates that, but I don't think that's widely considered a miracle drug. Sometimes we use trazodone as well, both for sleep or for agitated behavior, but the evidence is very, very poor. Kate, I don't know if you have more to add to that.
Yeah, it's really hard. I find often just thinking about what really is a problem and what is a problem. Like sometimes people have sleep, day-night reversal or shifts in their sleep schedule, and it's only a problem if it doesn't match the environment or the caregiver availability. So sometimes
is there like a cafeteria or a cafe somewhere?
Somebody is unmuted. Excellent. But I always try to dig in a little bit to like, what is the problem? Are there behaviors that are dangerous to the person or other people? That's one thing. What are exactly the behaviors? So you can dig into kind of what's going on before that. And that's a whole separate talk about like managing behaviors in dementia, but just really investigating what is the problem, because sometimes it's that the environment isn't matching the needs of the person, and there can be modifications that could be made to caregiver schedules or supports or activities that can be helpful. So it's complicated, but I find medication alone often is not a solution. It's a much more holistic approach, and leveraging your team, including the caregivers as part of that team to find solutions.
Caregiver training can go a really long way. And making sure there's no part of that caregiver training is making sure there's no unmet needs, like people aren't hungry or in pain or wet. So making sure that there aren't other things going on that are triggering those behaviors.
Thanks. Well, I want to make sure we have we have time for our case 2. Thank you so much for this talk. It was really helpful, and we'll send out with our resources that we send out afterward a link to your other modules that you have also in that QR code for the folks who weren't able to access it through the QR code right away. So we'll send that out. But yeah, thank you for sharing it, and thanks for all this work you're doing. I think it's so important to make sure that everyone who is working with older adults has a good understanding of dementia.